Uncomfortable topic, constipation. We have a specialist here to discuss it with us. I'm Dr. Paul Salza.
I'm Dr. Brad Weening.
Welcome to Talking with Docs. We have Dr. Carmen Fong here.
Thank you so much for having me, you guys.
Thank you for coming here, coming from Atlanta.
Atlanta. That's
But
right.
back home.
Yes, back home. My family actually lives in Toronto.
Okay,
There you
live
go.
in Toronto, but you're originally from Toronto, now working and living in Atlanta.
Yep.
We'll put your contacts in the description if anybody wants to find you after this. And you're going to be discussing constipation with us
That's right.
today.
Yep.
So Dr. Fong is a colorectal specialist, deals with everything from constipation to colon cancer, unfortunately,
Yep.
and everything in between. So we're going to talk about kind of what it looks like when you get it, what the physical exam looks like, how we investigate it, how we treat it, and really maybe most importantly, how we can prevent it, because that's probably where the
100%.
money lives,
Prevention
right?
is key. Yes.
All right.
Okay, so you're in the office,
Yep.
someone shows up, and they have constipation, but you don't know it yet. What are
Right.
they talking to you about in a setting like that?
I would say the most common things are people will be like, Doc, I can't poop, right? I can't poop, or when I poop, it's hard, or when I poop, I feel like I have to strain, or I'm sitting on the toilet for like 20 minutes at a time. And I'm like, oh God, that's bad. So my rule is 2 to 5 minutes max on the toilet.
On the toilet. Okay.
And then if you're straining, if you're feeling incomplete evacuation, like it's something stuck and it's not coming out, generally those are all symptoms of constipation, which, as you guys know, constipation is a constellation of symptoms, but it's also a functional bowel disorder, like according to the Rome 4 criteria, where you can have like chronic constipation and then IBS with constipation type, IBS, with diarrhea type, IBS mixed.
Okay, so those are all the different definitions of constipation. you're
Correct.
saying.
Yep.
Can you just run through them again one more time, asking for a friend
Right.
that missed it when you said that?
So like colloquially, there's actually 6 different types of constipation. It can be opioid-induced constipation.
Oh, we cost that a lot.
Right, exactly. So, after orthopedic surgery, they come back to the ER, they haven't pooped in 9 days, and I'm like, oh God, what are we doing?
Yeah, I'm sorry.
Yeah, so there's fiber and exercise induced, but then there's also drug and medication induced, bacterial induced. So you can actually have a C. diff that's a constipation type instead of diarrhea type.
Okay.
Yep, and then lastly is functional constipation disorders, which again is chronic constipation that's because of your anatomy and physiology, not really, due to all those other problems.
Okay, and is that probably the most common?
That is
type?
that is the most
functional
common,
one.
100%.
All right,
Yep.
but the other ones can happen. And when we say opioid induced, we mean after we perform surgery, we give you painkillers.
Painkillers.
And those narcotic painkillers slow down
Yep.
your bowels and can make you constipated. All right, so that is basically or what is really the
I was gonna
definition
say, yeah.
of constipation?
Yeah.
Like,
I know.
I'm
I
sure there
haven't
must be some
gone in
specific
3
criteria.
hours. I'm constipated. I haven't gone in 7.
Yeah.
What is it?
So my rule of thumb is that most bowel movement should happen 1 to 3 times a day, every 1 to 3 days.
Okay.
And if you're outside that window, you probably have symptoms of constipation. So if you're going less than once every 3 days.
Well, it's a rule of 3s.
Exactly.
1 to 3 times
Makes it
every
easy
1
to
to 3
remember.
days. And then on the toilet for 3 to 5 minutes.
3 to 5 minutes.
That's why our videos, we try and keep them 5 minutes.
Yes, exactly. So if people are scrolling
Yeah.
for 17
Yeah.
minutes.
Yeah. Brad, stop talking. I gotta get up.
That's right. That's how you know. Now,
Right.
And then, so really, what constipation is, though, for the average, you're like, well, why do I even get constipated? Essentially, it's that our food contents or our bowel
Yes.
contents, too much of the water is being absorbed, and it's not moving out of us quickly enough. Really,
Right.
that's the.
Exactly. Yeah. So we have all the definitions, but really, what's happening is that you're not eating enough, fiber or the right types of fiber.
Yeah.
You're not drinking enough water, even if you are eating a bunch of fiber, because fiber without water turns into concrete in the colon, like literally
Right.
just sit there and not move.
Right.
Or you're not moving enough. So moving around actually, as you guys always recommend.
up.
Yeah, get up and move around, because without that, your GI motility actually slows down as well.
Without movement. Okay. So how do you want to approach this? There's 6 different ones, so the treatments are probably different for each 6
Well,
different
can we do?
types.
You're in the office. Can we start with
Yes.
stick with the
Yeah.
exam and then the treatment, and then definitely
Yeah.
prevention for sure.
Yeah.
So they said to you, you're like, I'm highly suspicious this person has constipation just from their story. Like
Yep.
90% of medicine is that
Yep. Right.
history. So they're on the examining table. I'm assuming you're examining their abdomen.
Yep, exactly. So we do the history, we ask all of those things, like, are you having trouble evacuating? You can't poop, it's hard, blah, blah, blah. It's stuck for 3 days. And then do the physical exam. So I'm gonna feel their abdomen, right? I'm gonna palpate, both the left side. Most of the time, if there is like a hard impacted stool, you can feel it over here
Really?
in the left sigmoid colon, 100%. And then the most important part that, we do as colorectal surgeons is the digital anorectal exam. So instead of just DRE, it's actually now DARE, because we're actually also examining the anus and doing anoscopy. right?
Okay, so it's
mhm.
dare now.
Dare.
Dr. Dre's out.
Yeah.
Now we're daring.
I know,
to
Dre's
do-
out,
We're
it's
daring
dare.
to do the proper exam.
Yes.
And is that more because you're looking physically at the anus, like to inspect
Yeah,
it?
exactly.
For really
So-
external cancers.
For
Or
both,
hemorrhoids, I
yes,
guess.
exactly. So for hemorrhoids, for anal cancers, for any signs of obstruction.
Okay.
And then the most important thing for me is actually examining the pelvic floor and the sphincter muscles.
Right.
Because when you have constipation, another easy way to divide it is that it's either butt or gut. So, if it's an outlet obstruction, it tends to be butt, right? So something's not coming out, the door is closed and it can't get out.
Okay.
And then the gut is where the motility isn't happening or like the fiber and the water aren't happening.
Right.
Butt or gut.
And the reason she talks about the left side of our abdomen is because that's as our colon kind of
Yes.
goes throughout. The left side is where it's getting ready to leave. It's near the end.
Exactly.
Exit stage left.
Stage
That's what
left.
it said.
Exactly.
I don't think that's why.
No?
My guess is I don't think it was.
I think
it's
they have the
probably-
shepherds for
That's
like
right, yeah,
pulling
that's right.
people
Probably
out.
not, but I just.
No, but that's
Yeah.
perfect actually.
Yeah.
Exit stage left. Yes.
Okay, so you did the physical exam. You're
Yep.
like, okay, I did the anoscopy. I did the digital exam.
All
I'm
of
not-
that is normal.
Right.
Right.
I'm not worried about hemorrhoid or cancer.
Yep.
I've confirmed constipation. Do you do any extra tests? So orthopedics, we always order X-rays and sometimes a CT or an MRI. Does
Yeah.
that play any role in this?
Yeah, so there are actually a bunch of really good tests for constipation, but we reserve them for like after initial, period of like, conservative management, which is just we really want to try, diet, water, exercise for like 4 to 6 weeks at least, because the majority of the time, about 85% of the time, people will get better
Amazing.
with just increasing your fiber, right types of fiber, water. My 5 kind of tenets are soluble and insoluble fiber, 25 to 35 grams a day.
Okay.
2 to 3 liters of water, more if you're like extremely active in hot climates or pregnant, right? Because your circulating volume increases.
Right.
Exercise, so 30 minutes, about 3 times a week, still rule of 3s.
Yeah.
And then the other 2 important ones, though, are probiotics. So probiotics have actually been shown to improve the frequency of your stools, just not the consistency. So
Okay.
the softness is determined by the fiber, but how often you go is actually determined by your gut microbiome. And lastly is magnesium. So magnesium oxide is the only thing that's been proven right now to actually improve bowel movements, both frequency and consistency.
Supplement-wise. you
hmm
mean? Yeah.
Supplement-wise, yep.
Okay.
So over
So
the
2
counter.
questions about that. So for the probiotic, not for every person, but for every person that has constipation,
Correct.
should be on the table.
Yes, yep.
And then interesting about the oxide, isn't it magnesium citrate that is typically used essentially as a laxative?
Yes,
So
exactly.
oxide's better. according
Oxide
to-
is better.
Oh, okay.
Oxide is proven for chronic constipation. Citrate is what we use as a laxative.
Right.
If you haven't pooped, you drink a bottle of it, you go right
Right.
away. Sometimes we even use it as a colonoscopy prep.
Prep.
Yep,
But
exactly.
it's not a
So,
long-term.
but that's like a fast, diuretic type thing versus long-term chronic
Yeah.
type thing.
Okay.
When I was in university, the cure for me was the university exam. Right?
Okay,
and,
right.
and the laxative effect of the university exam was directly proportional to how much that exam was worth.
Yeah.
And how much you studied,
Sure.
maybe.
Yeah, this exam's worth 30%. I'm gonna have to go to the washroom
Right,
soon. This
right.
exam's worth 40%. Where's the nearest one?
Yeah.
This exam's worth 50%.
Oh, my.
I need new underwear.
That's a-
That's what it
that
was.
sounds like IBS. to me,
That
you
makes
know?
sense,
You
yeah.
know what? It could have been. This
This is
house-
where I get to talk.
Pre-exam
you and
cramping.
Carmen can talk after,
Yes.
after we stop
This was
going.
years ago. I don't write exams anymore.
Well,
so
No, I've actually had surgeons tell me that I always have to go before a long case in the
Sure.
OR, and you're
Yeah,
just
you
your
just don't
body's
wanna-
just like go.
Yeah.
Yeah.
yeah,
Mhm.
time
And
that
so would
out.
you typically start all 5 of those? Like if, say someone says, I don't have a lot of money.
Yeah.
What's like the most practical, kind of cheap place to start?
Fiber, water, exercise.
Fiber, water,
100%.
exercise.
Yeah.
Fiber, water,
And it's
exercise.
only because like those are the most common things, and in getting their history, sometimes people will come to me and say, I've already tried all those things,
Right.
and then so I start
Mm.
like cycling through
Maybe
all the
you
other
didn't.
things. Right.
When it comes to fiber, so obviously fruits, vegetables, grains, do you
Mhm.
tell them to take, do you have a favorite like a supplement of choice? Because I'm sure a lot of colorectal surgeons do.
Right. So I mean, technically, I don't love supplements, and I'm always like, get it from
Yeah, food.
get
We
it
love
from
it.
your diet.
That's what
But
we say.
the majority of the time, people are not getting it in their
No,
diet,
nothing
and they're
like
like running around like crazy. And so actually, right now, a lot of the companies will have fiber gummies, which have like 5 grams
Right.
of fiber each. So take 1 or 2, and then 1 fruit and vegetable at every meal, and that's really all you need to do.
Okay.
The other really cool proven thing right now is actually 2 kiwi fruit a day. So
Wow.
you eat 2 kiwi fruit a day, you will absolutely poop. It was in the British Medical Journal.
Is
a
that the
while
title
back.
of that journal article?
2 kiwi fruit a day. And
You'll
you'll poop.
absolutely poop.
And you'll
I
absolutely-
absolutely poop.
I actually had one patient come in and she started eating 6 a day,
Oh, gee.
and it started getting like way too acidic. So not 6 a
Yeah,
day, really
no.
just 2
That
a day.
exam's worth 70%. And
Wow,
so
interesting
when you
kiwi.
take the fiber,
Yeah.
you got me, then of course you got to be chugging water with
Yes,
that, right?
100%.
Water.
Yep.
And then you had mentioned probiotic. And what form is that? Like in a yogurt? Is it in a pill? Is it
Right.
in a supplement?
So you actually don't get enough, usually in a yogurt form, and sometimes not the right strains. So specifically for constipation, chronic constipation, you want Lactobacillus rhamnosus and Bifidobacterium, and most recently Bacillus coagulans is a very constipation, specific type of.
Those are the three that
probiotic.
you feel strongly about, Paul, if I remember.
Yeah.
Well, that's why I put them on my shirt.
Like
Duh.
Yeah.
Right?
And those are the best ones.
Okay.
So there's other types that you take for like antibiotic associated diarrhea, but those are the constipation type ones.
Okay.
Yep.
Got it.
Yep.
All right. And this you said 80% of the time.
85%
of the time it
Wow.
works every time.
Yeah.
They've done studies, 60% of the time it works every time.
That doesn't make sense.
Right.
Okay.
And it's just a matter of like, people are like, oh, I'm eating fiber, but are you really eating
Yeah.
fiber?
Yeah.
Do we know what fiber is?
Right. Do you ever
Yeah.
get in the journal? And do you ever get in the journal and say,
Yeah.
show me what you ate?
There's actually a good there's
App.
something
Oh,
called an
yeah.
app, something called an app. It's called the poop diary.
Ah.
And you can actually put your food and your kind of like pooping status in it.
Oh, that's handy.
Yeah.
All right. So these treatments are for the functional
Correct.
type of diet,
Yes.
which is
Yep.
the most common one.
Which is the most common one. In the majority of the time, we get them through those 4 to 6 weeks, and they'll come back and say, "Hey, doc, I'm pooping better." When they come back at those 4 to 6 weeks, and they're like, "No, I'm still not pooping," or this has been going on for like 12 years, and sometimes
Wow.
I go through cycles where I can poop.
Okay.
Then we start escalating.
Right.
So we kind of reserve these tests for refractory cases.
Okay.
So then we start doing MRI defecography. So MRI defecography is actually like a functional MRI where you have a bowel movement.
You poop in the MRI?
Mm-hmm. Yep.
Come on.
They told me
Yes.
not to do that.
Really?
Yes.
Wow.
So you put the contrast in the rectum and you actually, poop. And so poop the contrast out.
Okay.
So that we can see how your pelvic floor is working, whether there's laxity, where there's.
But it's a
intussusception.
dynamic test, like you're watching like a video,
Yes.
not.
Yep.
Okay.
Yep.
Wow.
Very, very cool.
Okay.
But that is actually one of the core tests for constipation. The second one is Sitzmark study. So Sitzmark studies I love, where you swallow radiopaque or a capsule with radiopaque markers. There's 24 markers in it, and on days 1, 3, and 5, you take X-rays and you can actually see where the radiopaque markers are in your colon. So this is for diagnosing, gut problems rather than butt problems.
Is that the virtual colonoscopy? Is that what that's not the
That's
virtual?
a pill with
Yeah,
the
it's a
camera.
pill.
Okay.
Yes, so that's a pill with a capsule endoscopy. And then there's also virtual CT, though, where you can do a CT scan and it has a 3D recreation of it.
Okay.
Wow.
So the barium enema is gone.
Because
When we were training, like we used to, I used to see that
exactly,
all the
yeah.
time. That was, for sure.
Most people don't do that anymore, but you can still do it, by injecting,
Right.
contrast in the rectum. You kind of see the anatomy.
Right.
But MRI is easier, like less user dependent.
Got it.
The Sitzmark is very easy and cheap. For a test, it's just a pill and a bunch of X-rays that shows you whether there's gut dysmotility or pelvic floor dysfunction. And then the last one, which we do in the office, is anal manometry. So really just
Okay.
testing your muscle sphincters to see if if all the other tests are normal and for some reason your muscles don't relax in your butt, literally things are going against the closed door and won't come out. So
Yeah.
after that, we go down the pathway of, okay, if it's gut, we're going to throw stronger medications at it. Or if it's butt, then we actually start with pelvic floor physical therapy. You can do things like, Botox injections to relax the muscles,
Oh, wow.
dilation. Things
So
like
interesting. So it's not that they don't work; it's that they work to their in spasm.
Yes.
Because obviously a lot of people are worried about incontinence. We've done videos with our
Yes.
Euro OBGs and like, okay,
Yeah.
I do those exercises to make
They're
them
too
strong.
tight, right? So
Interesting.
people actually will do Kegels and overdo them, and they're actually holding your spasm. You're holding your muscle too tight.
Wow.
A lot of times this is behavioral too. So like, us as surgeons, we're trained to be like, oh, don't go to the bathroom
Yeah.
all day.
Right.
And literally over time, your body just stays in spasm and doesn't know how to relax anymore.
And Botox is helpful for them.
Botox
I mean, like
is helpful
Brad,
for-
your wrinkles are gone and you're spending less time in the washroom.
Exactly.
It's the same stuff for your wrinkles. I can actually put
Yeah.
into your
Wow.
internal anal sphincter to
Wow.
relax that muscle.
And
You're like
because
younger
of,
through and through.
because of the location and like the dentate line, so can they feel that in the office? You have to.
No.
right?
So they don't feel it through the mucosa, but you feel it because it's intramuscular.
Sure.
And so I tell people it's
Interesting.
kind of like a flu shot. It feels like a sore, you're
Yeah,
putting
like an
an
achy
injection
arm.
in a muscle. That part hurts, for
Right.
sure.
Okay.
Okay. Now, what about the situations where it presents in the emergency room?
Yeah.
Okay, so this is like, constipation gone wrong, like
Right.
really bad.
really, really bad.
Can
yeah.
you touch on that, on
Right.
that situation?
And so again, sometimes this is like after orthopedic surgery, they
Yeah.
come in, they haven't pooped in 9 days because they've been on opioids. I'm just,
Yeah.
No, no,
Fair, fair. We
100%.
prescribe a lot of-
And especially the people that don't get up.
Yes,
Yeah.
it's exactly. It's the immobility. No, I was just going to say it's
Yeah.
the immobility, it's the opioids, it's the general anesthesia.
Yeah.
And so all of that makes a really bad, scenario for going to the bathroom. They come into the ER. I would say most often we go see them, we examine them, make sure they're not peritonitic, right? That their
Yes.
abdomen's like generally soft, even though they're distended,
Mm-hmm.
and not tender on palpation.
And when you say not peritonitic, that's to suggest, to make sure that they haven't ruptured or they don't have a perforation
Right,
where the bowel
exactly.
contents are in the abdomen.
in which case they would be very, very tender. Like when
Yeah.
you push on it, it hurts.
Yes.
Same thing, rectal exam if we can, anoscopy if we can, make sure there's nothing kind of stuck. And then they often go to the CT scan, right?
Okay.
In an ER, they will go to a CT scanner to make sure that there's, not like a unidentified colon cancer that we're missing or had, and so after that, there's one of two things. Depending on how severe it is, then, they get admitted and then they get, 4 liters of Go Lightly or Miralax, the same stuff, polyethylene glycol. So
That name, Go Lightly, it's just
Yeah.
so, it's like not lightly. Like
Not
there's
light
nothing
at
lightly
all.
about whoever
No.
named that. I know
There's
it's
nothing light.
electrolyte,
Yeah,
right?
no, I know.
Yeah, it's
There's
funny.
nothing light about it.
Yeah.
So it's always oral. So when do you decide to go like suppository and enema versus oral? You
Yeah.
always start with oral?
Right. So I think it depends on how distended they are.
Right.
So if they're very, very distended, putting 4 liters of fluid in them is actually going to make everything worse.
Mm-hmm.
And then you would start with enemas, suppositories. And then in the worst cases, especially if I did the exam, I can feel some fecal impaction or it's showing up on the CT scan.
Right.
And on the CT scan, you'll also see like some proctitis, right? Some
Right.
inflammation of the rectum, which,
Okay.
because the stool's been stuck there, then the rectum gets inflamed and it hurts. And then it makes it harder to poop, especially in elderly people. And then we really just go in and do a manual disimpaction. So
Okay, so for the average viewer, if you watch The Pit,
The
one of
Pit.
the episodes, I'm not sure if they made the second episode this year, they actually
Yes.
showed or talked about a manual disimpaction. It's what it sounds. So can you describe it for us? So
yeah, no, I love it. So actually they used to say, Dr. Fong, get Dr. Fong's rectal disimpaction tray, foreign body
Oh,
removal
wow.
tray.
You have your own tray.
I have my own tray.
do you have trainees where you work?
Yes.
Okay.
They'll send the intern. Send the intern, but often they'll be like, no, and I feel like it's a delicate matter.
Of
Like,
course.
It is
I will
delicate.
handle
For
it
the
myself.
patient, for sure.
Yeah,
Yeah, sure.
100% for the patient. I will handle it
Low,
myself.
Yeah.
low hanging fruit. if you may.
Like long gloves, get your gown on, and generally you're going to start gently, with the anus, kind of get your whole hand up there, and then when you can't remove it, then we start using a couple of instruments. We actually use like a little deaver sometimes, like little ice cream scoop type things. But most of the time,
And often you can
manually.
feel it like right away. Like you,
100%.
like it's like, okay, there's
No, it's
stool.
like right there.
Yeah.
I'm knocking on the door.
Yeah, it's right there.
If there was ever motivation to eat more fiber, let this
Let this
be
be it.
that motivation.
Yep. So then that brings us to prevention, though, right? So
Okay.
prevention
Yes.
is key, and I wrote a book called Constipation Nation, and literally
No
it's
way.
like prevention is key.
Oh,
Okay,
let's
we're
put a
gonna link.
to
Yeah,
that,
we'll definitely put a link.
Yeah. So and you really want to get to it before the problems happen, before
Yeah.
you haven't pooped in 3 days, and it's still kind of the same things, though. Fiber, water, exercise, and then get kind of addressing the problem early. So if you're like,
Right.
oh, I feel a little weird, go see someone, go see a doctor, right? You guys are always like, you're in charge of your own health. Like, go
Yeah.
see a doctor sooner.
Yeah, significant change in your bowel habits, regardless of it is too much, too
Right.
often, too
Oh,
runny,
okay,
too
so
soft.
now we're talking about some red flags here.
Yes,
Red
which
flags.
kind of
Can
leads
let's-
us to our next topic.
Yeah.
Yeah.
Okay,
Right, yeah.
so yeah, what would you say? So constipation red flag. You talked about your 1 to 3 times over 1 to 3 days. So if you get past that, that's
Mm-hmm. Yeah.
the first one. Go get some help.
Exactly. Yep.
What else would be on your short list of things I'm worried about?
Definitely blood.
Okay.
Right. So seeing bleeding, is going to be abnormal. Even now, we generally try to say that about 89–90% of the time, bright red blood is still from hemorrhoids or like anal fissure or something like that. But with the increasing incidence of like early onset, colorectal cancer, I'm always like, if you see blood, just go get it checked out, right?
Yes.
Because you can also have anal cancer that is bright red blood, but also painful with like a mass that I've seen get mistaken for.
Sounds like a
hemorrhoids.
fissure or hemorrhoid. Yeah,
Yep,
sure.
like tons of
Jeesh.
times. And it's very, very unfortunate. So just go see somebody as soon as you see blood. The other constellation of symptoms would be unintentional weight loss, right? So you're losing weight and you're not trying to. And then also abdominal bloating would be the primary ones. If you have a family history, obviously go, get checked sooner. And if you have a history of IBD, inflammatory bowel disease,
Right.
Right.
because we know that long term can develop into precancerous lesions.
And what about just last thing about the
Yeah.
poop itself?
Yeah.
If it's black,
Yes. Yep.
or if it's really, really thin.
Thin, right?
Yeah.
So changes in bowel, right? So if it's black, or if it's even like super white, actually,
Okay.
right? Which is rare. And then if thinner stools, pencil thin stools.
Got it.
Yeah.
Okay, so now, so we've covered constipation really well. Does it ever get to the point where it just causes an obstruction? You try to manual decompaction,
Disfaction, yep.
it doesn't work.
Right.
You've done everything you can, and it's just, but the patient's basically, can they get obstructed from this constipation?
So that's a good question, but I actually never have seen where we couldn't get all the poop out.
Really?
Okay.
So you've never
By nook or by crook, for sure, we can eventually get it out.
Okay.
Okay.
The rare instances, the one instance I can point to is in actually like a young man, chronic constipation, probably some element of Hirschsprung disease.
Okay.
And so no matter how
That
many
pediatric disease.
Yes, yeah. So
Yeah.
Hirschsprung's is where there's actually like, neurons that aren't working in
Yeah.
the rectum or a sigmoid, and so that segment of colon just doesn't work. So no matter how many times we disimpacted him and did whatever laxatives, kept coming back into the ER, and so eventually you have to do either a total abdominal colectomy or just a temporary ostomy, so bringing
Wow.
the colon to
Okay.
the outside into a bag.
Because I thought I remember fecal impaction being one of the possible causes of bowel obstruction on the differential
It
back
is.
in medical school.
It is,
But it's
yeah.
rare, you're saying.
It is. It's actually like probably the lowest one. The
As
top
surgeons, we always put it at the top of our list. Yeah, it's obviously us.
Fecal
Yeah, you haven't
impaction.
walked, you're taking
Yeah.
all sorts of
Look at the
morphine.
x-ray.
Right.
Yeah.
All right. Yeah. So it's actually, I mean, it's like an obstruction, but it's not a permanent obstruction, I
Yeah.
would say.
Yeah. I have a lot of patients, like when they're looking at their pelvic x-rays.
What's this?
Yeah, they're like, what's
All the
that?
fluffy
And you're
stuff.
like, okay,
Yeah.
well, that's poop.
Oh, that's funny.
Yeah, all the time.
All right, well, that's constipation. Wow.
Yes.
That is honestly,
is-
that's an awesome review. If you have something to share, our viewers love the comments from each
Yeah.
other. It's a little community that helps each other. If you have a trick that you've used that works, please include it. If you've had an experience, positive or negative, with constipation,
Yeah.
please share it. And if you like this video, please like it, subscribe to our channel, and share it with someone that you know is suffering from constipation.
And remember, you are in charge of your own health. And thank you very much.
of
That
course.
was
Thank you for
incredible
having me.
coverage.
Yeah.
And we're going to put all your contacts in our descriptions in case anybody wants to come and see
And the
you
book.
if they have a problem.
yeah.
Or you want to read the book. Let's put a link to the book too.
All right, we'll see you next time.